from the Center for Precision Medicine and Genomics, Precision Medicine for Cystic Fibrosis. Cystic Fibrosis, Precision Medicine for a Rare Disease. Presented by Emily DiMango, MD, Professor of Medicine from the Department of Medicine, Pulmonary.
I'm really excited to talk to you about how I think CF really exemplifies the power of precision medicine and translational medicine in really getting good health care and health outcomes to our patients. CF is the most common lethal genetic disease among Caucasians in the United States. It's inherited in an autosomal recessive fashion. In the US, there are about 27,000 people affected by CF, about 80,000 in the world. So it truly is a rare disease, which the NIH defines as fewer than 200,000 affected individuals. The disease is due to a mutation in the cystic fibrosis transmembrane regulator, or CFTR gene, that codes for a cyclic AMP-regulated chloride channel that is located in the apical membrane of glandular epithelium. So the disease really affects most organs that have glands. F508del is the most common mutation. In the United States, about 45% of people with cystic fibrosis are homozygous for F508del, and another 45% are compound heterozygotes. That's important because one of the precision medicine drugs I'm going to talk to you about targets this mutation specifically. The gene is located on the long arm of chromosome 7. It's a fairly large protein, a fairly large gene with 180,000 base pairs. To date, there are over 2,000 identified mutations. I'm going to take a minute to tell this group that Columbia University has a very long and distinguished history in cystic fibrosis. The disease was first identified here in 1938 by Dr. Dorothy Anderson, who was a pathologist who published a paper about cystic fibrosis of the pancreas. Many years later, Paul de Saint-Agnes, also at Columbia, was recognizing this was probably due to salt conductance abnormalities. And during a heat wave in New York City, it was apparent that many of these children with cystic fibrosis were presenting in electrolyte disarray. And from that and other testing, he developed the sweat test, which is still the gold standard for diagnosis today. In 1989, the gene was discovered by Francis Collins, who became director of the NIH and the Human Genome Project, and Lap Chi Choi from the University of Toronto. Some gene therapy trials were done very, very early on in the early 90s and failed for a variety of reasons, but fortunately that area of CF medicine is now being revisited. I mentioned that it's a fairly large protein. It sits on the apical surface of glandular epithelium, 2 membrane spanning domains, nucleotide binding domains, cytoskeleton domains as well. So it's the most common mutation is in a nucleotide binding domain here. This is a schematic of what happens when the CFTR channel is missing or not working. It's here in blue is the CFTR or chloride channel, which is responsible for efflux of chloride from the cell to the airway surface liquid, shown here in yellow. This chloride channel also has regulatory effects on sodium conductance, so on sodium channels. So to put it very simply, a mutation in the CFTR gene leads to defective or absent protein, which means there's deficient export of chloride into the airway surface liquid and increased import of sodium, influx of sodium into the cell from the airway surface liquid. So as a result, the airway surface liquid layer is markedly reduced. This is the fluid that bathes the airway epithelium, for example, in this schematic. So the mucus layer becomes very dehydrated with thick inspissated mucus. It impacts mucociliary clearance, which causes chronic bacterial infection and a very robust neutrophil predominant airway inflammation that leads to airway damage. The disease, as I mentioned, can affect many organs, anywhere that there's glandular epithelium. The pulmonary manifestations are the major cause of morbidity and mortality in the United States. Most patients with cystic fibrosis also have pancreatic insufficiency because of blockage of pancreatic ducts, usually in utero. So children are born with pancreatic insufficiency and need to take pancreatic enzymes to digest food. Most men with CF have congenital bilateral absence of the vas deferens. It causes elevation in sweat chloride levels and some other organ systems. This is a summary of, there are many different mutations, as I mentioned, that cause CF, and they've been separated into different classes. Class 1 mutations are usually due to a premature termination codon or an early stop codon. So what that means is a truncated protein gets made, never really gets to the cell surface. As you would imagine, that's a severe mutation. Class 2 mutation, and that's what the F508 del mutation belongs to. It's really a trafficking mutation where, because of amino acid substitutions, the CFTR protein is misfolded in a sense, gets recognized as an abnormal protein and really gets degraded by the Golgi apparatus before the CFTR channel ever even makes it to the cell membrane. So this also tends to be a severe mutation because there's minimal, if any, CFTR protein on the cell surface. And then these mutations, class 3, 4, and 5, are usually due to defective conductance across the chloride channel. So as you would imagine, when drugs were first being developed for CF, these kinds of drugs directed at the chloride channel, this was sort of low-hanging fruit. So high throughput screening was done to check the effectiveness of drugs to increase chloride conductance across the cell surface. And that, in fact, is how the first precision medicine or CFTR modulator drug was approved in 2012. This drug worked on class 3 mutations, which happened to be present in only about 3 to 5% of people with CF. So it didn't target a large number of patients, but it really showed that you can use high throughput screening to identify molecules to effectively, in this case, improve chloride conductance. Here's the mutated protein, and here's the protein, and here is the protein that's been treated with ivacaftor in this case, where you can see chloride conductance, which is inhibited here, is improved after treatment with ivacaftor. Before I present my case, I just wanted to give you a sense of what the treatment burden is in this disease. It leads to shortened survival, but it's also a very intense treatment burden for patients. Because of the thick airway secretions, people have to do airway clearance or chest physical therapy twice a day to try and vibrate the airways and expectorate the mucus. Patients have to take chronic suppressive inhaled antibiotics for Pseudomonas. They have to nebulize mucolytic therapy to thin out the mucus. That's alpha-dornase, DNase, hypertonic saline, anti-inflammatory therapy. Nutritional status is very closely associated with respiratory outcomes, and because of the pancreatic insufficiency and malabsorption, patients grow up having to eat a high-fat, high-calorie diet, taking pancreatic enzymes with all meals and snacks. Eventually, the pancreatic involvement starts to involve the endocrine cells as well, and up to 40% of adults develop diabetes, so we screen for diabetes once a year with a 2-hour glucose tolerance test. Patients come to clinic quarterly, exacerbations are treated aggressively. So very high treatment burden. Here's a summary of median predicted survival in CF. And you can see since the early 90s, it's been slowly but steadily going up. The slope of that curve is fortunately increasing. Now, highly effective modulators for the majority of populations became available in late 2019. Before that, all of the treatments that we had really treated the signs and symptoms of CF, not the underlying cause. But even with that, with better nutrition, use of mucolytics, aggressive treatment of infections, we did start to see consistent increase in median predicted survival. And in fact, when I started out, only about 1/3 of patients with CF were adults, but it was recognized that the adult population was going to grow, and that's why adult CF programs came into existence. More recently, almost 60% of all patients with CF are adults. So that's really been a marked development, and I think really speaks to the improvement in care. Okay, we'll switch now to a case presentation. Before I go on, does anybody have any questions or comments? Okay, so this is a 26-year-old man with CF who was diagnosed at 2 months of age due to failure to thrive because of the pancreatic involvement. He had malabsorption, did not gain weight early in life until he started taking pancreatic enzymes. He was homozygous for F508del. He transferred here to Columbia when he was age 21, and that's when he transferred from pediatric care at an outside institution to adult care here at Columbia. His sputum grows methicillin-resistant Staph aureus and Pseudomonas aeruginosa. About 70% of adults grow Pseudomonas aeruginosa. Growth of this organism is associated with more rapid decline in lung function, so we pay a lot of attention to it. On initial visit to our center, his FEV1 was 78% of predicted. FEV1 is the most sensitive marker of respiratory status and respiratory outcomes in CF. His course at the time was notable for frequent infectious exacerbations requiring intravenous antibiotics and hospitalizations up to 4 times per year. He went on an early modulator. I'll get into this a little bit more later. He went on an early modulator that wasn't quite as effective, but he didn't really have, like most patients across the country, didn't have much improvement with these early modulators. To remind you, the mutation that he has, F508del, is a trafficking mutation. Here in black is the mutated or abnormal protein that is misfolded, so gets destroyed within the Golgi apparatus, very little functional CFTR protein on cell surface, so severe mutation. Here on the right is electron microscopy in normal cells, showing here in green, you see the CFTR protein channel on the apical cell surface. And here in a cell with F508 mutation, the CFTR protein is all in the cytoplasm in the process of being degraded, never really makes it to where it's supposed to go. So this patient over time was not doing very well. Here is his FEV1 trend. It goes up and down a little bit. Every time it goes down is usually an infectious exacerbation treated with antibiotics. But you can see in general, the slope of the curve is not going in the right direction. He's having progressive decline of lung function, which is exactly what we see when patients reach their late teens and early 20s is when we start to see more rapid decline in lung function. His weight trajectory was, he was having more and more difficulty maintaining his weight. And as I mentioned, weight is very closely associated with respiratory health in CF. So despite the fact that he was on one modulator, he had participated in that trial. His father drove him to Ohio to participate in the early modulator trials. The family was so hopeful about these modulators. President Obama actually mentioned these modulators in his State of the Union address in 2010 as an introduction to the power of precision medicine in science. Anyway, as I mentioned, he wasn't really responding very well to those modulators. So he enrolled in a clinical trial of a new CFT modulator here at Columbia called the Lexicaptor, Tezacaftor, Ivacaftor, which subsequently was approved by the FDA called Trikafta. He was in the study for about 4 months and then went to open label for the first 2 years until the drug eventually got approved by the FDA. So how does this modulator work? It's 3 drugs, as you can see. Ivacaftor, I showed you briefly at the beginning, that's the potentiator. It opens up the chloride channel on the apical cell surface to improve chloride conductance. But you need to have a chloride channel on the apical cell surface in order to conduct chloride. And that's where Lexicaptor and Tezacaftor come in. Those are called correctors. They bind to the misfolded CFTR protein to allow some of the protein to avoid degradation in the cell and make it to the cell surface. So these correctors, here's the CFTR, misprocessed CFTR in the intracellular. But in the presence of these correctors, which bind to the misprocessed CFTR protein, cause some unfolding and allow some chloride channel to make it to the cell surface, you can see these correctors are in fact effective at getting some CFTR protein to the cell surface, and then the potentiator can come in and further activate chloride conductance in these abnormal chloride channels. So this is the drug that he went on, a triple therapy, 2 correctors and 1 potentiator. The drug he was on before was 1 corrector and 1 potentiator. So the addition of the second corrector had a very marked beneficial effect in clinical outcomes and chloride conductance. So here's his trajectory. He enrolled in the clinical trial right about here when we really started recognizing that we were getting into trouble with his progression of his lung disease. And you can see he had a marked improvement in his lung function after enrolling in the clinical trial that was sustained. And fortunately, there was an open label, so he didn't have to go off the drug. Similarly, as we expected, his weight went up. It's very hard to maintain a double-blind placebo-controlled trial in a drug that's this effective for the investigator and for the patient. You could really just walk into the room and tell who was on the drug versus placebo. Here are his pulmonary exacerbations. In green, I have frequency of oral antibiotics each year. In blue, IV antibiotics. You can imagine how disruptive intravenous antibiotics are for quality of life and just day-to-day life. Patients often have to get hospitalized for this. They're quite sick. So before enrollment in this clinical trial, lots of requirement for antibiotics for infectious exacerbations. And then soon after enrolling in the trial, his need for antibiotics essentially went away, except for here and there when he gets a cold and an exacerbation. This is not his chest x-ray because I didn't have it before and after. This is another patient who's also on modulator therapy where I did have it before and after radiograph. It's not always this apparent, but I showed this is one of the most dramatic ones. This is her chest x-ray before initiation of Trikafta, or highly effective modulator, and after. Bronchiectasis, we typically think of as scar tissue. So you would wonder, how does a X-ray or CAT scan get better after initiation of therapy? Well, a lot of these opacities we see are mucus plugging. And in fact, patients named it the purge after they started this medication. The first week or so were expectorating copious amounts of mucus from all of the mucus plugging in their airways. Here is the result of a clinical trial that was published in late 2019. And you can see here, patients taking placebo had stable on the y-axis, is FEV1. Patients taking placebo had stable to slight decline in FEV1 over the 24 weeks of the study. Patients taking active drug had an improvement of about 15% in FEV1. Now, this is a disease where, in general, on average, is a 2% decline in FEV1 per year. So a 15% decline, a 15% improvement in FEV1 that is sustained is quite remarkable. On the right is individual responses. You can see, as you would expect, here in the blue bars are the number of patients who have a certain amount of improvement in FEV1. There's variability, but almost everyone taking this drug has some improvement in FEV1. And the number of pulmonary exacerbations, just as we saw in my patient, goes down by about 65% overall, but the number of exacerbations requiring intravenous antibiotics goes down even more. And this drug, I'm sorry, this is a little blurry, but this drug does what we think it does. It gets into the body systemically, and you can see here that it causes a reduction in sweat chloride levels by about 45 millimoles per liter. So patients taking, whereas placebo did not change the sweat chloride, patients taking the drug started with an abnormal sweat chloride above 60, which is what's called abnormal, and most of them went into the normal range after starting the drug. So we see this 15% improvement in FEV1, which is wonderful. And we know that prior to modulators, a lot of the drugs we use, for example, alpha dornase, which is a mucolytic, leads to a 6% improvement in FEV1. But what's really important in this chronic progressive fatal disease is what it does to the trajectory of lung function over time. So I mentioned that in general, we see in the whole US population, we see about a 2% decline in FEV1 per year. So before modulators became widely used in late 2019, by the age of 40 or so, most people with CF either succumbed to their disease or needed a lung transplant because lung function went down into the 20 or 30% FEV1, 20 to 30% predicted range. If we had a drug that can even slow down progression by half to a 1% decline per year, we no longer have a disease that's life-shortening. So really, the bar is pretty high. We have to slow down progression by 50%, but that could really turn this into a non-fatal disease. So thinking about this data, and this was just published because Trikafta only came out a little over 3 years ago. In this study, here in dark blue is the control group, which over time, over the 2 years of this study, had about 1.92% decline in FEV1 per year, which is what we expect. But those taking Trikafta did not have a decline over time. They actually had this is over a fairly large cohort, over 2,000 patients. Those patients taking Trikafta did not have a decline over time. So we need more long-term data, but it really looks like this drug is slowing down disease progression and will hopefully turn CF into not a fatal disease, but a chronic disease that is manageable. So while it's not a cure, it really looks like it will significantly impact life expectancy. I want to tell you about a second case that was a little more challenging. This is a 39-year-old patient, actually, who just turned 40, who has a G542X mutation. That's a class 1 or premature termination codon mutation. His second mutation has not been identified despite genotyping. He has advanced lung disease, with recent decline in lung function prompting evaluation for lung transplant. So he is not modulator eligible based on his genotype. He's one of the 8% of patients who doesn't have a genotype that is responsive to modulator therapy. Over the past 2 years, he's had 2 to 3 exacerbations per year, 3 hospitalizations. He's getting sicker. He's starting to have episodes of massive hemoptysis requiring hospitalization. He's starting to need oxygen intermittently at home. His FEV1 declined from 38% predicted to 31% predicted over the past year and a half or so. He tried a drug called Adalurin that I'll show you in a minute. This drug was tested in CF. It's a drug for premature termination codons. It's called a read-through drug. He tried that. He was enrolled in a clinical trial here at Columbia in 2018. Unfortunately, that drug failed. As I mentioned, he doesn't qualify for modulators based on genotype. So he has a premature termination codon, a class 1 mutation. And what that means is the mRNA has this early stop signal. So a truncated protein gets produced in the cell, gets degraded. These patients have severe disease because there's really essentially no effective CFTR protein, no chloride conductance. Adalurin is a drug that works at the ribosome level. So while the ribosome is reading across the mRNA, stringing along a protein, in a premature termination codon, it stops prematurely, you get a truncated protein. Adalurin works in the ribosome to kind of, it gets complicated and I won't get into it and I probably would not do it justice anyway, but what the effect of Adalurin is that you get a near cognate transfer RNA so that you could read through this premature termination codon. You read through it and you can go to the end of the mRNA and produce a full-length protein. So that was the perceived mechanism of action. It went into phase 3 clinical trials. The clinical trial failed. None of the outcomes were met. There are some other read-through molecules being developed right now, but you can see how theoretically this makes sense for a mutation like this, but we just don't have a drug for it yet. So he was in that, didn't work out. So there is now serotyping being done for cystic fibrosis, and this is a mechanism to test CFTR modulators in vitro. And what we do is we obtain nasal scraping, so nasal epithelial cells. We do it right here in our clinic from our patients with these rare mutations. And we send them to Cincinnati Children's, where these epithelial cells are expanded in culture. They're grown on air-liquid interfaces. And then they're tested, almost like what high throughput screening was. Different modulators are tested on these cell cultures, and ion transport is measured in an Ussing chamber. And basically, it's a way to determine blindly if a modulator happens to work on this genotype combination. In 2020, the FDA actually used serotyping data that was provided by a pharmaceutical company to expand the genotype for CFTR modulators that included additional people with CF who had certain rare mutations. You know, obviously in a rare disease like this, the rationale is some of these rare mutations are only present in a handful of patients. You can't really conduct clinical trials, but if you theoretically expect that the drug would work, you now have a mechanism to test in vitro whether these drugs work. So we sent this patient's cells to Cincinnati Children's, to their serotyping center. I'll try and walk you through this. So the control is actually the patient's cells. The y-axis here is ion transport measured in an Ussing chamber on the air-liquid interface. Each lab kind of associates their ion transport with wild type CFTR activity. So this individual, this patient, at baseline, his wild type CFTR function was 3.3%, which is kind of what we see in CF, very low CFTR activity. After his cells were treated with ivacaftor, you can see ion transport measurement here went up significantly. And the CFTR association that the lab gave us is it went up from 3.3% of wild type to about 8.4% of wild type for this particular modulator. For another modulator, the ion transport did not go up as much. So based on this data, we wrote a letter to his insurance company and we requested that ivacaftor be approved, and it was in fact approved, and the patient started the drug about 3 or 4 months ago. I don't have any of those beautiful slides showing FEV1 and weight improvement, and I don't expect such a robust response. But clinically, the patient is doing extremely well. He feels well. His lung function just went up a couple of points from 31 to 34% of predicted. Other soft markers like 6-minute walk have improved. He's not needing oxygen. He has more energy. He can spend time with his twin children. He's feeling a lot better. So the response is not as robust as Trikafta was in my case 1, but I think it's very encouraging that we have a mechanism to test rare diseases for modulator therapy. So I showed you a couple of cases here, especially the first case looking at modulators. I just wanted to give you a sense of how this is impacting the CF community on a national level. This drug came out October 29th, 2019, and in just those few short years, we see dramatic effects. For example, prior to that, every year, about 250 people a year in the United States with CF needed a lung transplant. In 2020, the first year after this drug got approved, went down to 76. You might say that was a COVID phenomenon. It happens to have not been, because all other diseases like ILD, COPD, pulmonary hypertension, the numbers for transplant were pretty flat. And last year, only 32 people with CF needed a lung transplant. So this is right here, really, I think really tells the whole picture. This is really impacting people in a very major way. Similarly, people are starting to have babies. Women with CF are fertile, but because of thickened cervical mucus, their fertility rates are lower than the normal US population or the healthy US population. Soon after this drug was approved, we saw a big jump in number of pregnancies every year. Some women who were not using contraception because they never got pregnant were now getting pregnant. Other women were feeling healthy enough to carry pregnancy. So the number of pregnancies has gone up dramatically. So very good things are happening in CF in a very short period of time. It's very exciting. Here's mortality rate per 100 in the non-transplant individuals. steadily going down, and we see a sharp drop in mortality after the approval of highly effective modulators for the majority of CF patients. Before I end the talk, I'm just going to give you a few-minute update on gene therapy, which is, so we have this 8% of patients with these rare mutations that are not responsive to modulators, and the Cystic Fibrosis Foundation is diverting tremendous resources to expedite gene therapy trials, which are probably going to be the treatment that these patients will get. There are a lot of questions about it. There are a lot of questions about gene therapy. It's really not clear what the cell target is. I mean, probably the epithelial cells. Not clear how many cells in the airway epithelium need to be transduced. The drug is usually given by nebulized therapy. Will there be an immune response to the CFTR protein that's going to prevent subsequent gene delivery, because patients are developing an immune response to the protein or to the gene? What's the duration of expression once you do deliver the gene? How often do people need to be dosed? What's the timing of redosing and question of immunity? So a lot of questions have to be answered, but a couple of phase 1 trials have started in CF that look, and the results look exciting. I'm sorry for the quality of these slides. I took them from various talks that I saw on the internet or that I attended. So here are the first 3 patients that were dosed with mRNA being carried by an adeno-associated virus. There were 3 patients dosed across the first 3 patients dosed across the country. Quality of the slides is not great, but you can see here in the dark dots, the RNA probe does in fact show that there was gene delivery to the, I'm sorry, I said mRNA delivery, adeno-associated gene delivery. I misspoke. So there was a gene delivery to the epithelial cell surface here on endobronchial biopsies. And here are the 3 participants. This almost seems too good to be true. This is nebulized gene therapy, but about 40% of the epithelial cells stained on these endobronchial biopsies showed evidence of RNA, which I think is pretty remarkable. It appeared to be present in many epithelial cell types: basal cells, here marked with number 1, goblet cells marked with number 2, and columnar epithelial cells marked with number 3. So the gene does appear to get into various epithelial cells. And here, this was just presented last week, and this is the first time ever, because the question always is, if we know the gene is getting in now, but is the gene being translated? Is the protein being expressed? And last week, this was presented for the first time. Again, the quality of these slides is not great. And even the positive control here on the left with immunohistochemistry, you see it's pretty faint. But according to this slide, on these endobronchial biopsies with these dark brown dots, you can see that CFTR protein is present in the epithelial cells. So this is very exciting data. I think only fewer than 10 patients in the US have been dosed so far. We're about to start here at Columbia mRNA nanoparticle delivery in the next few weeks, which is Vertex Pharmaceuticals. So it's a very exciting time in gene therapy. Now, unfortunately, I mentioned 8% of people are not eligible for modulator therapies. Unfortunately, that is mostly present in individuals with minority backgrounds. So this is the number of patients with 0 copies of F508del. F508del is the mutation that is sensitive to these highly effective modulators. About 10% of white patients with CF don't have an F508del. About 30% of Hispanic patients with CF do not have a modulator responsive gene. 38% of Black people with CF do not have a modulator responsive gene, 40% of Asians. So there's a lot of work to be done here. And even in our own center, where we follow about 300 patients, about 13% of our patients are Black or Hispanic. We showed what many people have shown, that here, for example, FEV1 is significantly lower in people who are Black or Latinx compared to people who are white. So 11% significantly lower lung function in in minority patients. So health outcomes are already lower in that population, and this now is unfortunately only going to be compounded by the access to modulator therapy. So to summarize, precision medicine for CF has led to improved outcomes for over 92% of affected patients. Gene therapy trials are now underway for the remaining patients, and possibly in the future can be expanded to all people with CF. But I hope you have appreciated from what I told you that we're really very early on in this process. Funding for trials in this rare disease really started, it's worth mentioning, really started with grassroots fundraising by the Cystic Fibrosis Foundation, which was formed by parents of children with cystic fibrosis in the 1950s. Has been a very effective fundraising organization, and they really pushed pharma to study this rare disease, and that has obviously really come to fruition. So I really think a lot of credit is due there.
This was brought to you by the Center for Precision Medicine and Genomics at Columbia. This has been an internal medicine genetics case study.